Hello everyone, I'm Dr. Ushna Naveed from the AMC Smart Prep platform, and today's lecture is about the ECG interpretation. Whether you are talking about PLAB or AMC, USMLE, or simply looking for strengthening your clinical skills, ECG interpretation is a very essential competency for every healthcare professional. So in this session, we will basically break down the ECG interpretation into the simple, systematized, and help to identify the normal findings and recognize the common exam worthy abnormalities with a more confidence. So be with me till the end for the important tips and practice with examples, and you will be able to interpret the ECG that are very essential for your exam. And ECG interpretation is a very highest yield area of the AMC exam, and the many students struggle to interpret the ECG correctly. So let's begin. What is basically ECG? Okay, so introduction of the ECG. First of all, you should have an idea about the leads of the ECG. Before just rushing towards the ECG interpretation, the one very important information is leads. So these are the leads of the ECG, that is inferior, lateral, anterior, and septal, basic territories of your ECG interpretation. 2-3 AVF is an inferior lead, then 1 AVL, V5, V6 is the lateral one, V1 to V2 is anterior one, and V3, V4 is septal territory. By looking at this, just a visual picture, you will not be able to memorize everything, but on ECG, this is how the ECG leads looks like. Your 2-3 AVF, this is inferior lead. Then 1 AVL, V5, V6, this is your lateral territory. And the V1 to V4, this is your anterior leads. What I did for my exam, I made a quick short mnemonic to memorize all the leads together. That helped me a lot. And this is the quick way to remember the leads. Just take an example of this patient, that this is a normal patient for which you are interpreting the ECG. So remember 2-3 feet. Feet is at the bottom, inferior. So remember 2-3 and feet for AVF. This is for your inferior lead. Okay. So this is very easy to remember. 2-3 AVF, 2-3 feet. This is your inferior lead territory. Then remember this hand. Hand is your on your lateral side of the body. This is the medial side of the body. This is the lateral side of the body. So one hand with the 5 to 6 fingers, and on the lateral side, this is telling you about the lateral territory. So it's very easy to interpret it, that 1 AVL, L mean lateral side, and V5, V6. This is for your lateral lead territories. And you always knock at the front of the door. That means front V1 to V4. That is your anterior lead. Okay. So you are welcome from the front interior part of the door. That is your anterior lead. So this is very easy to remember. 2-3 feet, your inferior leads. 1 5 6 finger hand, which is your lateral lead, and the anterior door V1 to V4, this is your anterior or septal leads. So this much information you must know about reading the basic leads of the ECG whenever you are interpreting basically the territory involved in the ST elevation or non-ST elevation MI. This is very important. So make sure to take picture of this slide or to take 2-3 seconds to absorb this information. Then how you're going to read the ECG. We will not go into the much details that you have to read the rate, rhythm, axis, and all the things that you need to know about the ECG as a consultant. You need to pass the exam. Okay, so you need to know about the tricks and tips to make the ECG interpretation so clear for your exam. You do not need to go into the fancy details of the ECG. So by steps, you need to know rate, rhythm, QRS complex, ST segment, and you made the diagnosis. But we will just quickly make a short mnemonics and the short tricks for your exam oriented preparation. So what is rate? Rate, normally what we do, the RR interval, this is the quickest way to see the rate. Okay, so 1 hour block to next hour block, we have different parameters. This is 300, this is 150, then 100, 75, 60. So that's how, like 50, 40, 30, that's how you just count down the rate. But when the ECG is in front of you, at that moment you are not counting the blocks to see the rate. You will just have a look and you will be able to see that whether the rate is high or the rate is low. Like if your rate is too quick, okay, see these complexes and these complexes, just having a look, you are able to say that this is a tachycardia, this is a bradycardia. So anything which is rate less than 60 is your bradycardia. This tortoise, this slow running animal is your bradycardia. Or anything fast that is running so quickly, complexes are so close together, more than 100, this is your tachycardia. Okay, so your rabbit is your tachycardia. So easy to remember. 60 to 100 is the normal rate phenomena. Less than 60 is a bradycardia. More than 100 is your tachycardia. So that's so easy to just have a look and interpret whether you're talking about the bradycardia or the tachycardia. The next important thing, we have different disorders, and you should have a quick review that this is how the ECG is going to present and you are going to make the diagnosis. So first of all, you have complete heart block. So complete heart block, just think that the two couples who are divorced, they have no relationship with each other. Okay, so complete heart block, this is also known as grade 3. Okay, grade 3 or third degree block, complete heart block. So two couples are just divorced from each other. They do not have any relationship with each other. So P waves and QRS complex, they are independent to each other. Okay, P waves has its own rate and rhythm. QRS complex has its own rate and rhythm. They do not have any association with each other. Ideally, what happens in normal ECG, when you see the normal ECG, your rate and rhythm are so you can say concise to each other, and the every QRS complex should follow by the P wave. This is a P wave, this is a QRS complex, this is a T wave. Okay, so every QRS complex should be preceded by the P wave. This is a normal phenomena. But what happens in your complete heart block, your P wave is running independently. See, this is P wave, this is P wave, no QRS complex, again P wave, P wave, P wave, no QRS complex in between, and then QRS complex, no P wave. So everything, it's running on its own. So divorced couple, these are complete heart block. When you talk about the STEMI, ST elevation MI, think of this segment, your P wave, QRS complex, and this segment is known as ST segment. This should be on baseline. So anything that is elevated from the baseline, this is known as ST elevation MI. Remember, 2-3 feet, 2-3 feet. So when your elevation is in 2-3 AVF lead, you are talking about the inferior wall STEMI. So 2-3 feet, you are talking about inferior wall ST elevation MI. When you have front door, someone is knocking at the front door, V1 to V4, you are talking about anterior wall MI. So front door is always your anterior wall MI, and the 2-3 feet is always your inferior wall MI. So these are your ST elevation MI. Very important for your exam. Next, very important thing is your electrolyte changes. This is a very high yield topic for your exam. So remember, hyperkalemia means increased potassium. When your potassium is more than 5.5, 3 to 5.5 is normal. So anything when your potassium is more than 5.5, you will going to have this tented T wave. Okay, so normally our T wave are like this. Normally, small projection is going to be there. But in hyperkalemia, you have tall tented T wave, like a tent. Okay, so this sign, make a visual memory. This is your hyperkalemia, tall, peaked, tented T wave. As compared to this, in hypokalemia, remember this U goggles. This kid is having U goggles with the low potassium. So hyperkalemia, you are going to have after T wave a small projection which is known as U wave. Okay, so this is a normal phenomena. This is P wave, this is QRS complex, this is T wave. Now ideally there should be another P wave, QRS complex, and T wave. But in between these T wave and this P wave, you are going to have small projection which is basically known as U wave. This is additional wave that is present in the hypokalemia. So hypokalemia, somehow your ECG is prolonged, rate is slow, bradycardia, and you are going to have this U wave, U goggles for the hypokalemia. Next very important thing is VT, ventricular tachycardia. So remember this very fast train, very terrible train. Okay, so in VT what happens, you are going to have a monster ECG, a wide QRS complex, very broad QRS complexes is going to be there, very fast heart rate is going to be there, giant QRS complex due to this giant wheel. So remember, this train has very wide QRS complexes, more than 120 heart rate, and you're not able to see very beautiful P wave there. This is embedded in the QRS complex somehow. What you see on the ECG, just a very big, giant, bizarre QRS complexes. This is your VT, and this is an emergency. Okay, VT patient can deteriorate anytime. This is your emergency condition. Next important thing is SVT. So remember, SVT is somehow a fast driving racing car. The racing car is producing an image that has very small, narrow, complex QRS complexes, and the this is very identical to the normal ECG, but the rate is so high. Okay, so just take a concept. Whenever you have a beautiful concept of P QRS complex and T wave, every QRS complex is preceded by the P wave. This is known as sinus rhythm. Okay, sinus rhythm. Whenever you see P wave on your ECG, that means you are talking about the sinus rhythm. This is very important. So your SVT, sinus ventricular tachycardia or supraventricular tachycardia, you will have beautiful P wave. Every QRS complex is preceded by this beautiful P wave, and it will look pretty much like a normal ECG, but the rate will be so high, more than 150 to more than 200. This is your SVT, super fast racing car. Narrow complex. This was your white complex, ventricular origin, very terrible. So SVT is your narrow complex, regular rhythm, very fast, narrow QRS complex. Then is your atrial fibrillation. This is a very, very favorite topic of your AMC and USMLE most of the time. So atrial fibrillation, just remember this drunken drum beater. He just keeps on doing the music thing so randomly. So drunk drummer that is producing no rhythm, no pattern, no P wave you will be able to identify, just an irregular complexes that are producing by the sounds. Okay, no rhythm with each other, any sound is going on produced by this drummer. So no P wave. Whenever you are not able to appreciate the P wave and the rhythm is irregular, that means you are talking about your atrial fibrillation. Okay, so atrial fibrillation is a very, very high yield topic for your exam. Just remember this as such. The next important thing is digoxin toxicity. This is somewhat, you can say, a difficult ECG to interpret. This should not be in your exam as a medical graduate, but AMC, USMLE, even FCPS, they love to ask about the digoxin toxicity as well. So you should learn about the what digoxin toxicity looks like on ECG. So we have different changes of digoxin toxicity. When you have too much digoxin, your heart is sick. Okay, so first of all, you are going to have stooped ST depression. This is known as reverse tick sign. This is very particular for the digoxin. They can mention this sign in the stem also, in the scenario also, or they can show the ECG as well. You should be able to interpret the ECG. You should be able to remember this sign as a reverse tick sign. So see, a downward sloping, like a skating sloping like a journey, you can say. So this sloping scooped ST depression is very typical for your digoxin toxicity. Then you are going to have narrow complexes like shortened QT interval. This are so close to each other. You can have flat inverted T wave. See, this T wave is downward deflected. Normally the T wave should be this QRS complex. This is the T wave. Normally it should be like this, upward deflection. But now either the T wave is going to be flat, not like a good projection, but or it can be reversed downward negatively. And you're going to have PR prolongation. Okay, so distance between the P wave and distance between the R wave, this is somehow prolonged. So any of these features can be present into your digoxin toxicity. But the most important one is your reverse tick sign. Okay, so make a visual memory of this reverse tick sign. This is very, very important for your exam. This exactly comes in your exam, and you should be able to interpret that how you're going to deal with the digoxin toxicity. And just a quick question, that what is the antidote of digoxin toxicity? If you just think about the antidote, if I give you 3 seconds, that what is the antidote of digoxin toxicity? Remember, this is DG bind. DG bind is your digoxin antidote. Very important one for your exam. Okay, so remember this as such. Then we have another ECG that is known as Wolff Parkinson disease. Again, this is a difficult ECG, but again, EMC loves to ask about the Wolff Parkinson white ECG or WPW. We called it as WPW. Like digoxin toxicity, the specific finding was reverse tick sign. WPW also has a very important sign, which is known as delta wave. Okay, so what is delta wave? Normally what happens? This is our complex, P wave, QRS complex, and you are going to have T wave. This is your normal complex. But what happens in WPW? Your P wave then you are going to have short PR interval. This interval is not that much like a normal ECG interval. You are going to have short PR interval, and there is no downward deflection of R wave. There is a quick upward deflection, okay, like up slanting or slurred upward stroke. This is known as delta wave. So this delta wave, this sign, this straightening, this is very particular for the WPW. There is going to be very minor change, but your eye should be able to recognize this sign, okay? Slurred upstroking of the QRS complex, this straight line, this is known as delta wave. Normally you should have like this, okay? This is your complex and then T wave, but now instead of this downward deflection, you are going to have a slight slurred upward delta wave. This is very particular for your accessory pathway, okay? So whenever your discharge is produced by the SA node, instead of going to the ventricle, this is taking an accessory pathway, and this accessory pathway is mentioned by the delta wave. So delta is presenting with the WPW. The patient is going to have tachycardia, patient is going to have AVRT, white QRS complex can be there, low PR interval can be there, and delta wave. That is very particular for the Parkinson disease, full Parkinson white disease. So whatever we have learned so far, I hope you should be very clear in your mind that what we are talking about. So just a quick quiz time. You will be given 3 seconds. Take a paper and make a diagnosis, and at the end see that how you are able to interpret the ECG. So first of all, what is this ECG? Okay, I'll just give you 3 seconds. Make a picture of this, make a visual memory of this, and try to answer on the paper that how are you going to interpret this ECG? What is the answer? Okay, so the answer is your atrial fibrillation. How many of you have correctly interpret this ECG? Okay, you can tell me in the comment box, or you can just make your answer at the end. Okay, so what is the marks you have get? So no P wave here, you are not able to see a beautiful P wave here, and there is irregular rhythm. Why irregularly irregular? See, this is an interval, this is shortened, this is longer, this is again somehow variable, this is not matching with any interval, again longer. So this is irregular rhythm. No rhythm is matching with the other complex. So this is irregular rhythm with the absent P wave. This is known as atrial fibrillation. Okay, so next one. Just a 3 second quick review. Try to solve the interpretation. Stepwise approach, rate, rhythm, access, whatever, or quick memory. How you are going to interpret the ECG. Just 3, 2, 1 second. Quick. So see, you are able to see this upward deflections there. This is somehow the upward stroke is going to be there. So what one AVL produces if there is an ST elevation in the one AVL? Remember, we did lateral STEMI, lateral wall MI, that person with the hand of one hand with a 5-6 finger laterally placed. So this is known as 1 AVL V5 V6. You are going to have lateral wall MI. So this one ST elevation, your AVL ST elevation, somehow just a little elevation from the V5 V6, not a very pronounced, but you will be able to see one AVL straightforward that you are dealing with the ST elevation MI, lateral ST elevation MI. Okay, so next one. This is a bit tricky. You should be able to have a keen eye to just observe the findings which are very minute in this ECG. So what you are able to see in this ECG, just approach like normal ECG, go for the P wave, go for the normal rhythm, whether this is regular, whether this is irregular, whether this is broad complex, whether this is narrow complex. Are you able to see any ST elevation? So stepwise approach, okay? You are able to see the P wave, a very beautiful P wave is there, every lead, very beautiful P wave is going to be there. So we are talking about the sinus rhythm. This is a sinus ECG. You are able to see the rhythm, every rhythm is so regular. So we are not talking about the atrial fibrillation, the rhythm is so regular. And you are not able to appreciate any ST elevation. T wave is just normally placed on the baseline. Every T wave is so beautifully placed on the normal axis. So what you are able to see, just a minor changes. Are you able to see this slurred upstroke? This one, slurred upstroke, there. What we have to talk about reverse tick. Okay, so this just not reverse take, sorry, slurred upstroke delta wave. Okay, so this is WPW, delta wave, just a slight slurred upstroke of your QRS complex, just a minor changes. This one, slurred upstroke of your QRS complex. So this is known as delta wave, very typical for the WPW, and that this is a very favorite ECG of your exam. Just try to solve some ECGs, some CT scans, some X-rays as a cow theory. If you are able to see so many deers in a farm, and there is a one cow standing in between the deers, you will easily say, okay, this is a cow. You do not need to understand what is the color of the cow, what are the features of the cow. Your mind, your eye will quickly catch the cow. So that's how you have to remember the WPW ECG, that if you have seen so many normal ECGs and something is going on abnormal, you will quickly say this is something abnormal. Okay, so just make WPW a cow for your eye. That is a very important. Mostly they called it as elephant theory, that if you have so many cows in the farm, and you will be able to see the elephant so quickly. So this is just an elephant for you guys. Okay, so this slurred upstroke of the QRS complex, that is going to be your delta wave, WPW, very specific. Next, remember this beautiful reverse take and the small U wave that is just after this reverse take. This is just like a mustaches of this person, reverse take. And this reverse take, this U-shaped downward sloping scooped ST depression, this is very typical for your digoxin effect, digoxin toxicity. So again, make this elephant for you guys, that this mustaches sign, that is basically scooped ST depression, this is U-shaped ST depression, this is like this. Okay, so this is your digoxin toxicity, very important for your exam. So that's all about the important ECGs we have discussed so far. If you want to learn any topic, you can tell me in the comment section, and just subscribe the channel to get updated whatever I'm teaching about the AMC section and the important mnemonics, and whatever topic you find it very difficult, like regarding screening, ethics, any other topic you love to ask, you can comment in the comment section. I would love to read your comments, and I would really appreciate if you are just suggesting any topic to read from me. Okay, so I'm Dr. Ushna Naveed. I'm from Smart Prep. Telegram and WhatsApp links are available in the description box. If you want to join for the paid or unpaid sessions for the AMC preparation, you are more than welcome. Thank you so much.